Welcome to Doctors on Call. I'm Jenna Miller. March is National Colorectal Cancer Awareness Month. Approximately 140,000 people in the United States will be diagnosed with colon cancer this year. Overall, the lifetime risk of developing colorectal cancer is about 1 in 23 for men and 1 in 25 for women. In the U.S., colorectal cancer is the third leading cause of cancer-related deaths in men and women. Early stages of colorectal cancer usually present no symptoms. It is highly treatable if detected early. With the recent passing of Chadwick Boseman from colorectal cancer, we are reminded more than ever of the importance of screening early for this cancer, even in the midst of a pandemic. Routine screening is safe and should not be delayed. Colorectal cancer can be prevented and lives saved. Joining us tonight to answer your questions on colorectal cancer is our guest, Dr. Perez Tamayo from Central Care Cancer Center.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Regional Hospital, experts, neighbors, friends.
Colorectal cancer is our topic this evening on Doctors on Call. Dr. Perez Tamayo is a radiation oncologist and president of Central Care Cancer Center. Dr. Perez Tamayo completed her radiation oncology residency at the Medical College of Wisconsin. She was awarded prestigious fellowships to both the American College of Radiology and the American College of Radiation Oncology for her contributions and service through education, research, and service activities in the practice of radiation oncology. Her academic appointments include the University of Michigan and the University of Kansas Medical Center. She participated with the American College of Radiology Commission on Small and Rural Practices, was appointed to the President's Cancer Panel, and is a part of the Kansas Comprehensive Cancer Control Panel. Dr. Perez Tamayo is board certified by the American Board of Radiology and the American Board of Internal Medicine, subspecialty of hospice and palliative medicine. She has expertise in brain and body stereotactic procedures along with high-dose rate brachytherapy. Dr. Perez Tamayo sees patients at Central Care Cancer Center in Great Bend, Newton, Emporia, and Kansas City locations, as well as at Heartland Cancer Center in Garden City. In 2018, Dr. Perez Tamayo earned the Lifetime Achievement Award from the Wichita Business Journal for her long-standing commitment to treating oncology patients in Kansas. Please give us a call at 800-337-4788 toll-free with your medical questions about colorectal cancer on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much, Dr. Perez Tamayo, for coming and being our guest tonight. We have a question right off the bat that was emailed to us. This is from Andrew, and his question is, will you explain further what Lynch syndrome is, and are there other mutations like this associated with colorectal cancer?
Thank you. Yes, actually, Lynch syndrome, Dr. Lynch from actually Nebraska, described a situation where this is a non-polyposis type of syndrome where you have cancers of different sorts. It can even be a glioblastoma of the brain that you may have in the family, and as you start seeing that there's different members of the family that have colon cancer, breast cancer, polyps, maybe not cancerous, or a brain cancer. And all of a sudden, these conglomerate cancers start becoming awfully noticeable that these are happening. And it's not non-polyposis, meaning that you don't have to necessarily have a polyp to be susceptible for cancers of the colon and other cancers. Now, there are different conditions that are inflammatory in nature, like Crohn's disease and other diseases of this type that are irritating the colon and can promote a cancer of the colon. There's other Busch-Jaeger. There's many syndromes that can cause cancer of the colon, but it is not the most really common reason for cancer of the colon. You mentioned that 140 to 150,000 people are diagnosed a year, but sadly, 30%, 50,000 will die, again, with a curable and extremely well described disease that can be picked up early in its inception. So the plea is that yes, you may have one of these syndromes, which is very rare, but the majority of the cancers of the colon are not with syndromes. They actually start in a polyp usually, a polyp that could have been removed with a colonoscopy, and then that's it. You will never develop cancer of the colon. So the new guidelines are that anybody at 45 or older should have a colonoscopy done at least once every 10 years.
Very good information. Thank you so much. And thank you, Andrew, for your emailed question. How does the Central Care Cancer Center utilize a team approach to treating cancer patients?
Well, again, if it's very early, and early meaning that it is within the colon and invading only the initial lining, because it starts in the lining of the colon. These are usually adenocarcinomas, which means they are coming from a mucus-forming gland that gets irritated or becomes a polyp. It becomes dysplastic, it becomes atypical in its growth, and then it starts invading the muscle layer. So if you have just an early cancer, even removing it with during the colonoscopy or is a procedure that is purely just to remove it is enough. Then of course, since these sometimes are not noticeable because you don't have the typical symptoms of bleeding or obstruction or pain, or for instance anemia, the number one, incredibly enough, the number one symptom for cancer of the colon is being tired. Why? Because you're anemic. You've been losing a drop a day for years, and all of a sudden you just feel like, why? People are diagnosed with iron deficiency anemia, or what people would consider a microcytic anemia, and it is because of this loss of blood. And then all of a sudden you need a workup, because why are you losing blood? Why do you have this anemia? And it is because the cancer has already eroded or caused an ulceration, and then it's usually later. So here again, with the number one the number one mainstay of treating is early with surgery. Now, barring that, again, anatomically, depending on where this cancer is, you will approach it in a different way, and again with staging, especially in the rectal area, which are very, very approachable by a digital exam. The sphincter, what enables you to have a bowel movement, is there. So what you want to do is preserve that sphincter so you don't have to have a bag. So this is when we do a preoperative chemotherapy radiation approach to shrink the tumor away from the sphincter, so when they do the surgery, then you can have your sphincter functioning. So it is very important to try to spare not only the sphincter because of the ability to use it and not have to have a bag, but also because it downstages you, and you become from a stage 2, T2, T3 down to a T1 or T0. Now, as you go higher up into the colon, into the colon, and we're talking about the large colon only when we're talking about colon cancer. There's small bowel, that's not what we're talking about, but the colon. So as you go into the ascending colon, and you go and you flex down into the transverse colon, and you go down to the descending colon, you end up in a cecum. The cecum is what receives the food from the small bowel. That is a big pocket. So many things can grow there very large before you even know you have something. And that's usually when you see the later stages in this part of the colon, because it is silent. It's like a bag that can really have a huge mass and you would not notice it. And unfortunately, the liver is nearby. So once it starts getting out of this bag, it starts attaching to the surrounding structures. So it is very important, again, that if you have some idea about your body and you're thinking, I'm not having the normal bowel movements, or I'm constipated and have diarrhea, or I have black stools, or I have blood in the stools, don't wait. Don't think, it's hemorrhoids. It's better to get it checked out, because the likelihood that if it is cancer and it's still early, you can get rid of it.
Okay, we are going to go to the phone lines. We've got Sarah on the line from Sterling. Go ahead with your question for Dr. Perez Tamayo tonight. Sarah?
Yes. Are you there?
Yes, we are. Go ahead with your question. You step away from your TV so you don't get that feedback.
Okay.
Go
ahead,
we're
we're-
ready.
Okay. I can't, it's awful loud on your,
If either you can turn your TV down or you can go into another room and then you won't hear yourself talking.
okay, I have my TV on mute, so it's
Okay.
not,
Okay, go ahead. We can hear you just fine.
okay. Now I can go ahead and go, right?
Yes, you sure can.
Okay. They have tried several different times to give me a colonoscopy, and they say I have a kink in my colon, and that I was wondering what can be done. It makes having a bowel movement kind of difficult.
Well, mostly the kinks in the colons are due to adhesions. Adhesions due to anything like a past surgery or endometriosis in the case of a woman. And these kinks should actually be considered as a medical situation that needs to be taken care of with a simple maybe excision, because it will get thicker. Scar tissue are caused by fibroblasts. Fibroblasts are actually living cells, and these cells get denser with time. So if you don't address it in time, meaning in 5 years, you may be blocked up completely. So even though the colonoscopy is extremely important, the adhesion or the kink needs to be taken care of. Now, there are other ways of diagnosing cancer of the colon by DNA testing, for instance, of the stool, and it has its pros and cons. There's a lot of false positives, a lot of false negatives. It is done more frequently than a colonoscopy every 4 years. But also there's sometimes you may even be a candidate for a little camera it's a pill that you swallow, and they can see your colon throughout the navigation of this little camera. So I think the number one thing to do is to go to a specialist, a GI specialist or a gastrointestinal specialist, and see if your kink should not be addressed, because it's only going to get worse.
Okay, great information. Are at-home colon cancer screening tests effective?
They're very effective. Unfortunately, they are very much dependent on on the person that is doing it yourself. What is your technique? That's why there's so many false positives and false negatives. And you have to do it more frequently. And it is not for everyone. If you have cancer of the colon in your family, this is not for you. The colonoscopy, there is really no substitute. Yes, and there's other things. There's a radiology test. In fact, there's virtual colonoscopies that can be done. And perhaps this lady that had the kink, maybe that's a way of doing things as well. But you really need to find out, especially if you have cancer of the colon in your family. There is a downtrend in having the 65 and 60-year-olds having colon cancer, but there's an uptrend in the people that are between 40 and 50. But you can have people when they are in their 20s have colon cancer. So you really shouldn't say, oh gosh, I'm too young to have cancer of the colon. You're never too young. We have, unfortunately, right now a father and son colon cancer that we're treating. And remember, this is very important. The coelomic cavity, or the cavity where your colon is a cavity. If you've ever dressed a chicken, you know this. And so what happens is when things get out of the cavity, like if you were piercing a sausage, what's going to get to it that you can't get medicine to it because there is no blood supply? So you don't want to have seeds coming out of your colon and start seeding your coelomic cavity. So here again, ignoring it is only going to get worse. And blockages due to seeds is very, very difficult to deal with.
Okay, we're going to go back to the phone lines. We've got Dawn on the line from Salina. Hi, Dawn. Go ahead with your question for Dr. Perez Tamayo. You are live on the air, Dawn. Are you there?
I am here.
Okay, go ahead with your question.
Doctor, this is Dawn. Thank you for taking my question. My question is, how long does it take benign polyps that are in the colon to develop into cancer?
Okay, that's a great question, because it's a question that is actually it applies to all cells of your body that are malignant or tumors, because tumor is a Latin word for abnormal growth. Each 5 millimeters of tissue takes, it's 1 million cells in a quarter of an inch. And the growth of cancer is exponential, meaning you don't grow 2 plus 2 is 4 plus 2 is 6. That's mathematical growth. We're talking about exponential growth. So 2 to the second power is 4. 4 to the second power is 16. 16 to the second power, and so on. So you can imagine in a quarter of an inch, you have 1 million cells. Put that to the second power in your calculator, and it's overwhelming. So when people think, gosh, it grew overnight, it's not really that it has grown faster. It's just that at a certain point, you have 10 million cells growing to the second power, wham, it grows quickly. So the polyps usually take a while to grow. That's why you need to do the screening, because it takes, for a small polyp, and not all polyps are necessarily going to turn into cancer. There's some, and that's why I always ask my patients, make sure you get a copy of your pathology. There are some cancer, some polyps that are premalignant, like a serraceous polyp, like a serrated knife. That's not good. Don't ever look at that and say it's okay. No. Or atypical polyps. But there's some polyps that are just basically warts. They're not really anything that's going to turn into anything. But why have an obstruction? Because these warts can grow to be very big, and then they become obstructive.
What can a person expect during a colonoscopy?
The colonoscopy, I always say, is a great experience. I know it sounds strange, but it isn't. What happens is the medications that they give you make you relax to such an extent that muscles that you didn't know you had, like even your ears, become nice and relaxed. So that's really not the problem. And before you know it, you're done. And the worst part is that they wake you up and you're really not ready to be woken up. However, the prep is where the whole thing is. The prep is a difficult thing, and you're going to get, the colonoscopy is completely proportional to the effort that you put in having that colon clean. Imagine looking inside a tunnel and having all this stool there. You're not going to see much. So you need to make sure that you follow your doctor's instructions, and there's different types depending on the medications you have, your age, etc., what type of prep you're going to have. But you want to make sure that you give the doctor the best chance to evaluate you.
And what are the stages of colorectal cancer?
Colorectal cancer is staged by, number one, the T, or the tumor, how big it is and how invasive it is into the muscle. The muscle has different layers, and then there is a serosa, or basically the casing. When the casing is basically pierced by the cancer, we call it a T3. While if it's just in the mucosa, we could be a T0, meaning just the beginning, or it could be a T1. Then there's the N part, or the nodes. Nodal involvement. Nodes are filters that filter impurities. We have them all over. There's hundreds and thousands, millions of nodes throughout our body. So every part of our body has a certain cells that go to certain filters to make sure that if it is, for instance, an infection, that you get it taken care of. Unfortunately, when it comes to cancer, it is your own body producing this, so it doesn't know what to do with it. It's you made this, so should we fight it? No. So then that's the end part, and depending on where the nodes are, whether they are regional, meaning around where the colon is supposed to go, or if they're distant, then it makes a difference. And then the M part is metastasis, meaning has it gone into the blood supply to other organs like the liver and the lung. Now, depending on where the colon cancer is, it can go directly into the liver or directly into the lung. For instance, the superior hemorrhoidal veins and inferior hemorrhoidal veins go to different parts of your body directly. So here again, the spread is dependent on your anatomy.
And how far have you come in treating colorectal cancer?
Well, there's new medications all the time, and usually these medications, unfortunately, are for the higher stage cancer, because again, you go from a 100% curable situation when you have a small tumor to almost an impossible situation. Again, 30% people will die because of the spread. So when we are talking about cancers that have gone beyond the lymph nodes into the bloodstream, then we have the typical chemotherapies that work, and then we have higher levels if there is resistance. And those are focused immunologic agents, Or for instance, if it's invaded your liver, there's some radio substance that have isotopes, meaning there is actually radioactive material that go directly into the cancer. Usually it's yttrium, which is a very shallow type of emitter, and it goes directly into the cancer because it is tagged by something that attracts this substance into the cancer. But unfortunately, all of these nuances are for the later stages. Again, screening, this is a preventable cancer, highly curable. Don't delay.
And after diagnosis, what is the first step for the patient and their caregivers?
The first step, of course, is to, if it is early, is to go ahead and have it removed. Usually, however, even if it's early, if it's down near your sphincter, you're going to have a preoperative treatment with radiation and chemotherapy because it's a very high price to pay to lose your sphincter. Having to have a bag for the rest of your life is something most people don't want to do. So even if it's early, if it's very low down near the sphincter, the radiation and chemotherapy are the first thing to do. Downstage the cancer so that the resection can be done. And here again, it's the resection sometimes has to be done with special technique and special tools because it's like a surgery if somebody knows how to sew, it's able to staple together very closely. So that's number one. Then and usually the treatment is very easy on the body. So again, it's only you may get tired, but that's it. The aftercare, if it is a colostomy, is a little more complicated. And sometimes you have to have a colostomy because there is no way to put it together, and then that's that.
How involved do you feel a cancer patient should be with their treatment options?
With all cancers, the captain of the ship is the patient. You have to be part of the team and, in fact, the leader of the team. And of course, we have a lot of people assisting you, the nurses, the therapists, the doctors, the family. But if you're not willing, if you don't want to do it, no matter what we do, it cannot be done. Nobody is forced into trying to get well. So wellness is an important part of the treatment. And there are some groups, for instance, African American, the Inuit, Alaskan Indian, that have a huge risk of having cancer of the colon. If you have diabetes, you have a higher risk. So there are certain populations that require a little more time, and you need to be interested in going ahead and turning yourself into the authorities and getting your colonoscopy done.
Now, is there anything a person can do to help prevent colorectal?
Well, yes, and I am very much about living the organic life. I think that many times we want to blame some food substance that may be giving us a higher risk, and high fat, for instance, diet is one of them. But many times it's really what is in the food. We have a lot of organic solvents in the herbicides, insecticides, in the vegetables. So you think, I'm a vegetarian, I'm going to do fine. That's not how it is. Some waters you need to have tested to make sure you don't have these organic solvents. And then in addition, you need to eat grass-fed, grass-finished beef and meats. The same thing, organically grown, everything is the best. How we used to eat before is definitely better than having something that has many chemicals in them.
And when a person is told they're in remission, what exactly does that mean?
Well, remission is a very interesting word because it may mean nothing. It means that everything is just stable, but doesn't mean you've gotten better. Some people want to hear the word and think it has a lot of meaning, but it isn't. You want to be cured. That's the word. And this is a curable cancer.
Sure. So if a person is cured or is in remission, is there a chance that they will go back into?
If they're in
cancer?
remission, yes. In remission meaning that they're holding tight, but it doesn't mean they're cured. You never are in remission if you're cured. If you're cured, you're cured. Now, can it come back? Of course, because whatever caused this to happen in one part of the colon can happen in another. In fact, in some of these syndromes, like the Lynch syndrome, you may have your colon removed without cancer. So there are some things that have to be done preventative that are very hard on you because you go, oh my gosh, am I going to have my colon removed? It's a huge price to pay, but if that is the price you have to have, like in breast cancer, you may have to have your breast removed prophylactically, and so can be the colon.
Well, our thanks goes out to
Thank
Dr.
you.
Perez Tamayo for being our guest tonight on Doctors on Call. We were talking about colorectal cancer. Thank you so much for joining us. On our next Doctors on Call, we'll be getting an update on COVID-19 with Dr. Tyrell Summers from Russell. You can email questions to us for our next program at doctors@shttv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Russell Regional Hospital, experts, neighbors, friends.